Important topic because I was in MAPICON last week and Dr. Rajiv Gupta, the best person who is taking on this hypertension, when we interacted, he suggested to focus on hypertension in young. So we are also analyzing the data of 25,000 patients we collected during May Measurement Month of hypertension in young, especially in Indian setup. So I must congratulate you picked up this topic and really burning topic in present day scenario.
Thank you so much, sir, for the kind introduction. First of all, a very good afternoon to all present. I extend my heartfelt gratitude to the organizing team of MAPICON, especially Professor Dr. Vitull Gupta, for giving me this opportunity to speak on a very important topic, which is hypertension in young. Hypertension, as we all know, is the most common non-communicable disease all over the world. Its prevalence and incidence is increasing at a startling rate all over the world, especially in Asia. Despite this, its proportion in the young population is largely underestimated both by the medical and the non-medical community. Because of this, a large chunk of this population is still undiagnosed, and most of them are even unaware of the severe complications of this so-called benign entity. So with this, first we see the key points of today's talk. Hypertension in young, there is no fixed age for defining hypertension in young, but most of the previous literature says that any individual who develops hypertension between the age of 18 to 40 can be labeled as a young hypertensive. As I've said, it is not uncommon. In fact, 1 in 8 individuals between the ages of 20 to 40 years are affected with it. The incidence is rising day by day because of the modern lifestyle and due to ever reducing hypertension thresholds in different guidelines, especially the last guideline issued by AHA, where the hypertension threshold has been reduced to 130 by 80. The treatment is often delayed, and it is very important that we screen for secondary hypertension and monogenic hypertension in these individuals. Now, hypertension as such affects almost 25% of the global population. It is the leading modifiable risk factor for cardiovascular morbidity and mortality. We can imagine that if a young individual develops hypertension, say at the age of 20-25, the chances of cardiovascular and cerebrovascular complications will be all the more, and they will tend to appear at an earlier age. So this is the population that we need to diagnose early, treat early, and screen early for complications. Now, this was a large ICMR study which was concluded in 2023. It was published in Lancet. It found the prevalence of hypertension in India at a very high value, that is 35.5%, almost 1/3 of the entire population being affected by hypertension. Now, these are startling figures. It also found that hypertension was the most common non-communicable metabolic disorders among all the other disorders like diabetes, prediabetes, metabolic syndrome, and dyslipidemia. World over, the prevalence of hypertension is also high in the younger population. The incidence is more than 10%, and there has been a tremendous increase in the proportion of hypertension in young individuals. In fact, in the last decade, we have seen almost doubling of the number of individuals who present at an early age with hypertension. This was another Indian study which concluded in 2020 and published in 2020, which found the prevalence of hypertension between 20 to 40% in the urban adults and 12 to 17% in the rural adults. Even in this study, the individuals between the ages of 20 to 44% had a high prevalence of hypertension. It was 26.7%. Now, if we compare this data with the US counterparts, in US, the prevalence of hypertension in this age group was only 10.5%. So with this, we can actually understand the magnitude of hypertension in the young population in our country. The ironical part is this is only the tip of the iceberg because many of the individuals are still undiagnosed. So Ministry of Health in 2019 to 2021 conducted their 5th round of National Family Health Survey, and they found that the prevalence of hypertension in the young individuals was 17.6%. Now, despite a high prevalence and a high incidence of hypertension in these young individuals, there are certain barriers to controlling hypertension. What are those barriers? Most important is altered health identity. The young individuals do not accept the diagnosis of hypertension. The physicians as well as the patients show great reluctance in starting antihypertensive medication. There is a definite gender difference. Males tend to fare Males tend to decrease their follow-up visits. Females are more compliant with the antihypertensive medication and with the frequent follow-ups. There is a great blood pressure variability. There is a great diurnal variation of blood pressure in these individuals, which further increases the chances of cardiovascular morbidity and mortality. And the visit adherence in this population is also very low. Now, different guidelines propose different definition for hypertension. We'll follow the International Society of Hypertension guidelines, which clearly state that any individual with a systolic BP of more than equal to 140 and a diastolic BP of more than equal to 90 can be labeled as hypertension. But most of the guidelines also state that ambulatory blood pressure monitoring should be the gold standard for diagnosis of hypertension. So if we are using ambulatory blood pressure monitoring, the 24-hour average is taken as more than equal to 130 and diastolic more than equal to 80 to label anyone as hypertensive. The AHA guidelines, on the other hand, state that any individual who has a systolic BP more than equal to 130 and a diastolic BP more than equal to 80 is a hypertensive. Now, the pathophysiology of hypertension in young individuals is very complex. Most of the individuals are males, and most of them show a isolated systolic hypertension phenotype. That is because of increased sympathetic tone. So increased sympathetic tone leads to increased stroke volume, increased cardiac output. On the other hand, the females tend to show isolated diastolic hypertension phenotype or systodiastolic hypertension. That is due to increased peripheral vascular resistance, and that is due to increased stimulation of the renin, angiotensin, aldosterone system. So it has been observed that the young males who are hypertensive tend to have a cardiac hypertension phenotype, whereas young females tend to have a vascular phenotype. What are the important risk factors? Family history and genetic factors obviously play a big part. A very interesting hypothesis was given by Barker and Brenner, which was termed as developmental origins of health and disease hypothesis. It states that there are certain perinatal factors which govern the occurrence of hypertension in the young individuals. Now, what are those perinatal factors? One is fetal IUGR, low birth weight, preterm babies, and if their mother had hypertensive disease of the pregnancy. These individuals are at a far greater risk to develop hypertension in young. Other traditional risk factors we all are aware of are sedentary lifestyle, high intake of salt, metabolic syndrome, high alcohol consumption, smoking, consumption of tobacco products, consumption of illegal drugs, etc. Now, there are two types of hypertension. One is primary hypertension, also termed as essential hypertension. This is the most common phenotype. It doesn't have an underlying cause. The family history plays a very big part, and there is a very big contribution of metabolic syndrome and obesity. Second is the secondary hypertension. It is very important that we screen all young hypertensives for secondary hypertension because these causes are potentially curable. Approximately 10% of the individuals have secondary hypertension, and secondary hypertension proportion has an inverse proportion with age. That is, as the age advances, the chances of secondary hypertension reduce. So the causes for secondary hypertension are more prevalent in school-going age. Now, what are the factors which should make us suspect a patient for secondary hypertension? Obviously, first is if a patient comes to us with a high blood pressure and he is less than 40 years of age. If a patient comes to us with drug-resistant hypertension, there is severe hypertension at presentation. Patient straight away comes to you in the ER with history of frank pulmonary edema, malignant hypertension, or a stroke. Then you should suspect secondary hypertension. There is a sudden deterioration in the blood pressure control. You are following up the patient for 2 to 2.5 years, and suddenly your patient has stopped responding to the traditional drugs. If you do an ambulatory blood pressure monitoring and you find a strong non-dipping status and presence of hypertension-mediated organ damage, all of these factors should lead you to suspect secondary hypertension. What are the important causes for secondary hypertension? Most important causes are the renovascular and the renal. In renovascular, we should rule out fibromuscular dysplasia and atherosclerosis. There are numerous endocrinopathies which also lead to secondary hypertension, most important being thyroid disorders, both hypo and hyperthyroidism, hyperparathyroidism, primary hyperaldosteronism, Cushing syndrome, and pheochromocytoma. Other miscellaneous causes are coarctation of aorta and obstructive sleep apnea syndromes. What is monogenic hypertension? Monogenic hypertension is again an important entity which is associated with hypertension in young, and it arises from specific gene mutations. Obviously, it has a very strong family history, and these syndromes, since they have a genetic predisposition, they tend to present early in life. Now, what are the factors which should enable you to suspect monogenic hypertension? One is young onset hypertension, presence of low renin, persistent electrolyte abnormalities, especially potassium and bicarbonate. This should lead you to suspect aldosterone hypersecretion. So brachydactyly, disorders of adrenal steroids like congenital adrenal hyperplasia, and a strong family history of young onset hypertension, myocardial infarction, sudden cardiac death, stroke in a first degree relative. And the most important part for today's talk is how to evaluate a young patient who comes to you with a high BP measurement. First, we have to ensure that whether that patient has hypertension or not. Second is, if that patient is diagnosed with hypertension, you have to assess the cardiovascular risk. You have to assess for the end organ damage, and then you have to screen for the secondary causes of hypertension. If a patient comes to you in the office, you take his blood pressure, you cannot label that patient hypertension on a single reading. Ideally, this has to be done on 2 different occasions. The patient should be relaxed for 5 to 10 minutes. You have to take at least 3 readings, and you take the average of last 2 readings. These readings have to be taken at 1 to 2 minutes apart. If your patient is found to have high blood pressure on both the occasions, you should subject the patient to ambulatory blood pressure monitoring to confirm the diagnosis of hypertension. What are the clinical features of hypertension in young? Apparently, most patients are asymptomatic and they are diagnosed incidentally. They come to you for another pathology, you check their BP and found them to be hypertensive. There are very few patients who come with hypertensive headache. They are the ones who have severe hypertension. They present with a classical occipital headache, which is more in the morning. There are certain patients who directly present to you with hypertensive emergency, like frank pulmonary edema, congestive heart failure, renal failure, or a MI. Now, what are the investigations which you have to do to assess for cardiovascular risk and to assess for end organ damage? ECG has to be done for all patients, followed by 2D echo. 2D echo is meant to find out left ventricular hypertrophy. That gives you an idea that for how long your patient is hypertension. Then you have to look for systolic and diastolic dysfunction. You have to look for the dilated atria and other chamber dimensions. Blood tests which are routinely ordered are LFT, RFT, HbA1c, lipid profile, thyroid profile. You have to do a fundus examination for all the young hypertensives to rule out hypertensive retinopathy. And urine routine examination, especially urine albumin to creatinine ratio, has to be done for all to look for microalbuminuria. Now, this is the fundus of a young hypertensive male. You can observe the cotton wool spots, and plus you can hardly see the margins of the optic discs. So there is obliteration of the optic disc margins. Now, how do we diagnose secondary hypertension? Most important is to rule out renovascular and the renal causes. There are certain clinical features which give you important clinical clues. One of them is abrupt onset of hypertension, severe or resistant hypertension, If a patient comes to you with hematuria, oliguria, pedal edema, dyspnea, again you should suspect renovascular or renal causes. And one important history is a patient being diagnosed as hypertension and given an ACE inhibitor or ARB, and you follow up that patient for 4 to 8 weeks, and you find a sudden deterioration in the estimated GFR. There is an increase in the serum creatinine, then you should strongly suspect a renovascular cause. Some of these patients may also present with flash pulmonary edema, and on examination you can find abdominal bruit, especially a renal artery bruit. What are the important lab investigations you should order? First being RFT, then urine routine examination. We should order a plasma renin level which will be high. And ultrasound can show either a unilateral or a bilateral atrophic kidney. The investigation of choice for renovascular hypertension are a Doppler arterial ultrasound, a CT or a MR angiography. If available, we can also go in for captopril enhanced radioisotope renal scan. Now this is the CT. On your left, you can see a CT angiogram, which is classically showing stenosis of the right renal artery. And on the other panel, you can see the classical string of beads appearance, which is very classical of fibromuscular dysplasia. So when to suspect a patient for Cushing syndrome? When a patient presents to you with classical features of Cushing's like truncal obesity, moon face, proximal myopathy, osteoporosis, buffalo hump, purple striae, and easy bruisability. Simple investigations to be ordered are 24-hour urinary cortisol level followed by a dexamethasone suppression test. Now, when to suspect pheochromocytoma? Pheochromocytoma typically presents with episodic hypertension. There are multiple episodes of severe headache, palpitation, sweating, panic attacks, and pallor. Investigations to be done are screening can be done by a serum metanephrine level. Diagnosis is by 24-hour urinary metanephrine or normetanephrine level. Pheochromocytoma can be localized by a CT or a MRI, and if available, we can go in for MIBG scintigraphy. Now, when should we suspect our patient to be having coarctation of aorta? It classically presents in school-going children who either present with an innocent murmur or hypertension. You check the blood pressure in both the limbs, there can be discrepancy. You check pressure in the left upper limb and the left lower limb, and you can find a marked difference in blood pressure in the two limbs. It can also be suspected whenever there is a radio-radial delay or a radio-femoral delay, and it is 8 times more common among boys. Now, coarctation of aorta can be easily diagnosed on a chest X-ray, which shows a classical 3 sign, which I'll show you subsequently. You can also find rib notching, which is due to intercostal collaterals. A barium swallow may show a reverse 3 sign. Definitive diagnosis is by magnetic resonance iotography. Now, the classical 3 sign is actually formed by a pre-stenotic segment, which is the aortic knuckle. It is followed by the coarctic segment, and then there is dilatation of the post-stenotic segment, which leads to a classical 3 sign. One can also see the rib notching in the red arrows. Now, which guidelines should we follow for managing a patient with hypertension? We'll stick to the Indian guidelines and the European guidelines. Both say that any hypertensive young male who has a BP more than equal to 140/90 can be put on drug therapy. But if the patient already has diabetes, CKD, cardiovascular disorder, or familial hypercholesterolemia, then this threshold may be lowered to 130/80 millimeters of mercury. And most of the international guidelines advocate that an ambulatory blood pressure monitoring is a must to confirm the diagnosis of hypertension. AHA guidelines also advocate the same. They say that stage 1 hypertensive have to be treated if they have an established cardiovascular disease, or if the 10-year atherosclerotic cardiovascular disease risk is more than 10%. Otherwise, irrespective of comorbidities, any patient with a BP more than equal to 140/90 needs to be put on lifestyle modification and pharmacotherapy. Now, treatment for hypertension should always be a multidiscipline approach should always be a holistic approach. And very important, which we tend to ignore, is the lifestyle modification. So most important is weight reduction. BMI has to be kept below 25. Dietary salt intake should be less than 6 grams of salt per day. Advice for a DASH type of diet with more amount of fruits, vegetables, low fat dairy products, and low amount of saturated fats in diet. The alcohol consumption has to be reduced, smoking has to be stopped, tobacco products consumption have to be stopped, and patient should be advised to go in for physical activity, at least 30 minutes of physical activity for 5 days a week. This is a very busy slide, but we'll take a few important clues from this. This is the GNC 8 treatment guideline. It gives us definite target goals. So first goal is, if your patient is not a diabetic, not a CKD, our goal is to reduce the blood pressure to less than 140/90. However, if your patient is either CKD or having diabetes, then your target is less than 130/80. And 3 different strategies can be used. Strategy A is, we start with a monotherapy, then follow up the patient, increase the dose to the maximum permissible limit. Strategy B is, we start with a single drug, then follow up the patient, and a second drug may be added without first increasing the dose of the first drug. And strategy C is, we start with a combination therapy right from the outset. This is advisable when the systolic BP is more than 20 above the threshold and diastolic BP more than 10 above the target goal. All of this have to be complemented by lifestyle modification measures, which we have just discussed. Now we'll focus more on the Indian guidelines. For younger individuals, the drugs of choice are ACE inhibitors and ARBs. But before that, in case of a young female, you have to exclude pregnancy and you have to exclude conception. If the target goal is not achieved with either an ACE inhibitor or ARB, we can either add a calcium channel blocker or a diuretic. In step 3, if the BP is still not controlled, we give all the 3 drugs together, ACE inhibitor or ARB with a calcium channel blocker and a diuretic. If the BP is still not controlled, it is termed as resistant hypertension. If your patient has resistant hypertension, you have to add another agent, which is mineralocorticoid receptor antagonist in the form of spironolactone or eplerenone. If the BP is still not controlled, the other options we have are beta blockers, alpha blockers, and centrally acting agents. So pregnancy is another very important entity in young individuals. If the patient is pregnant, we cannot give ACE inhibitor or ARB. If the patient is planning to conceive, then ACE inhibitor or ARB have to be substituted by a safer option like labetalol, nifedipine, or methyl dopa. So how frequent the follow-up should be? It should be at least after 3 months. So prior to 3 months, we should not try to change either the dose or the drug regimen. So to summarize, hypertension in general and hypertension in young is tip of the iceberg. Although the prevalence and incidence is already high, but there are many more who are still undiagnosed and unaware. It is important that we diagnose them timely and treat them timely. The number of young adults with hypertension are increasing globally on a rapid pace. If early onset of hypertension is there in the young population, many of them will end up with cardiovascular and cerebrovascular morbidity and mortality. This will affect the financial and the productional age of the society. It is important that we rule out secondary causes, although the number is less than 10%, but these are the patients who are potentially curable. Treatment has to be started. Most of the guidelines say treatment has to be started when the BP is more than equal to 140/90. These can be lowered if patient already has diabetes, chronic kidney disease, and established cardiovascular disease or familial hypercholesterolemia. While tackling a female young patient, do rule out pregnancy. If pregnancy is detected or patient is planning to conceive, do not give ACE inhibitor or ARB. For rest of the population, ACE inhibitors and ARBs are the drugs of the choice. Thank you for your patient listening.
Thank you, Dr. Sumit, for touching this rather important topic briefly and explained very well.
Thank you, sir.
And I suggest, as I was sensitized to work in hypertension in young, you are in a good institute with very high patient load. I think you should also have some data in hypertension in young. Thank
Sir,
you very much.
Thank you so much, sir. Thank you.